Hello guys, I hope you're ready for the discussion of those 5 questions that I posted today. That was based on a question that I posted yesterday. It was not a question, a learning post that I posted yesterday, the fish and the eye. So we had bilateral corneal clouding, which is seen in fish eye disease, if you remember. Okay, so the first question was mutation of which gene causes fish eye disease. So the options that I had given you were RPE65, LCAT gene, APCA4 and APCA1 gene, alright. So the answer to this particular question, that is what gene mutation results in fish eye disease, it is LCAT gene. Now what is this LCAT gene? Lecithin acyl transferase gene. Okay, LCAT is lecithin acyl transferase gene. Alright. Now what is this LCAT? I'll just talk to you in a little bit about LCAT. Now before that, quickly we'll run through option A, C and D. Option A, RPE65 gene mutation. RPE65 mutation is seen with retinitis pigmentosa and also with congenital Leber's amaurosis. Alright. Now coming to option C, which is APCA4 gene. APCA4 gene mutation is seen in Stargardt's disease. Okay, APCA4 gene mutation is seen in Stargardt's disease. Now what is APCA1 gene? Now APCA1 gene again is something to do with cholesterol and it is seen in Tangier's disease. Okay, it is seen in Tangier's disease. Alright, so now you know 4 genes and 4 different diseases, out of which 3 are eye diseases and 1 is Tangier's disease. Of course, it has some eye findings as well, which I will tell you in a little while. Okay, now Tangier's disease, anything else, one like a quiz question or a short question. Have you heard of orange colored tonsils? Orange colored tonsils are seen in Tangier's disease. That is because of the excessive amount of lipids which get accumulated in the tonsils. Alright. Now coming to this LCAT. Now what is LCAT? Again, it is lecithin acyl transferase enzyme which is involved in the reverse transport of cholesterol. Okay, reverse cholesterol transport, what you call it is RCT or RTC. Now what is this reverse cholesterol transport? Now before I tell you about RCT, I will just tell you a little bit about this gene. This gene is located on the long arm of chromosome 16. Okay, long arm of chromosome 16. Now this gene mutation actually affects, it causes 2 diseases. One is a fish eye disease where it's a partial deficiency of this enzyme, and when there's a complete deficiency of this enzyme, it's called as Norum's disease. Okay, it's called Norum's disease. I think that was the next question. So you already know the answer for the next question. So Norum's disease is a complete deficiency of LCAT, and this is a partial deficiency of LCAT, which is fish eye disease. Okay, so shall we discuss a little bit of biochem, because I know biochem is very, very volatile. So I'll tell you a small thing about this LCAT. Okay, now what is this reverse cholesterol transport? Okay, for that let's talk about like a layman. Okay, we all say, no, arey cholesterol yahan pe it is accumulated in the heart, there is cholesterol, in the arteries there is cholesterol. Okay, fat jam gaya, right? So now you want to take that, body has a mechanism to take that cholesterol from these peripheral tissues back into the liver, because from the liver it can always be excreted into the bile. Yes, so this is reverse cholesterol transport. Now how does it achieve it? So the mastermind again is liver. Okay, so now liver is going to produce 3 things among a lot of other things. Now for this what I need is, I need HAL. What is HAL? Hindustan Aeronautic Limited. Okay, all of you saw the air show in Bangalore. Okay, so HAL conducts an aero show. So now I'm going to use the same HAL for this. Okay, what is HDL? The high density lipoprotein. Okay, you know high density lipoprotein, HDL is a good cholesterol. So the good cholesterol is being secreted by the liver. Now what is A? ApoA1. Now this ApoA1 makes the major component of my HDL. See, why do I call it HDL? High density. What does it contain like that? It contains this high density protein. What protein? This ApoA1. So it's ApoA1 is also secreted by the liver. Now what is this L? L is the one we are talking about, LCAT. So this enzyme LCAT is also produced by this liver. So HDL, the nascent HDL, okay, the baby HDL. The baby HDL molecule, when it is secreted by the liver, it contains A, it contains L. Now this L is in an inactive form, alright. Now in the peripheral tissue, this A will activate L, got it? This A is going to activate LCAT. Now what is this LCAT going to do in the peripheral tissue? Now my heart has, let's say, cholesterol. Now I want to take the cholesterol, my HDL wants to take the cholesterol from the heart and take it back to the liver so that it is, metabolized, right? So now for that, my cholesterol has to be transported to the HDL molecule. So that transport is done by APCA1. You remember APCA1? I just talked to you about APCA1. It is an ATP binding cassette, okay? So APCA1 helps in transport of this cholesterol from my heart tissue, that is my peripheral tissue, or any of your peripheral tissues, from there into my HDL molecule. So if I have some deficiency of APCA4, okay, or if I have a mutation of APCA4 gene, I will get Tangier's disease. Now what is Tangier's disease? You remember I told you about this orange tonsil, okay? So now you also know what does APCA4 do. Now my cholesterol is in my HDL. Now my APO1, okay, you remember HAL. So my APO-A1 is going to activate LCAT. Now what is this LCAT going to do? It is going to esterify my cholesterol. So it's going to make my free cholesterol into a cholesterol ester, so that's easier to transport. So now what happens is a physical change in the conformational change or a configurational change of my HDL molecule. Now I call this HDL as a mature HDL, okay? So it's like nice and like a sphere. It's easier to transport in the blood. And where does it go now? It goes back to the liver. So my mature HDL, what I call as HDLC, that means HDL with cholesterol. So now this goes back to the liver. It goes into the liver. Now the liver has two options. So in the liver you have what is called as a scavenger receptor B, okay? So this HDL is going to interact with this molecule and then the liver takes it up. Now two things can be done by the liver. The liver can excrete the cholesterol into bile, as part of your bile salts, or it can incorporate it into VLDL molecules. So now my heart is free of cholesterol. You understand why we call HDL the good cholesterol? Because it takes away all the cholesterol deposits from all your peripheral tissues. Is that clear? So now this LCAT deficiency, when it's completely deficient, you call it as Norum's disease, and when it's partially deficient, it's called, you get this fisheye disease. Is that clear? Now what do I mean by partial? Now this LCAT activity is present both in HDL and also in LDL, both in the good cholesterol and in the bad cholesterol. Now when I say partial deficiency, that is in fisheye disease, the activity is still retained in the bad cholesterol, but my good cholesterol does not have LCAT activity. That's why it's called partial. Whereas in your Norum's disease, it's absent completely. Neither in the LDL nor in the HDL you have APO-A1. Is that clear? So now when I have absence of LCAT, I have free cholesterol everywhere. Lot of free cholesterol in the peripheral tissues and also in the blood. So what's going to happen is this cholesterol gets deposited. So that's exactly why you have cholesterol deposition in both Norum's disease and also in fisheye disease. Now what's the difference between fisheye disease and Norum's cholesterol deposition? See, in fisheye disease, if you see that picture that I've already posted, you have a complete deposition all over the cornea from limbus to limbus. So the entire cornea is cloudy. Whereas if you see in Forum's disease with the picture I'll be posting in a short while, you'll see that it's only at the limbus. Okay, it's only at the limbus, very dense at the limbus. Okay. Now do you know of any other cholesterol deposition at the limbal area? Yes, you all know that there is an annular deposition in arcus senilis. Yes, so it's in the Bowman's layer and also in the stroma. Now what is the difference between Norum's and arcus senilis? Now all of you know in arcus senilis we have something called this lucid interval of Vogt. I'll show you the pictures, okay? So lucid interval of Vogt, between the limbus and the deposition you will have a clear area, okay, a clear interval. Whereas In Norum's disease, you will not have that. You will have a thick yellow one with no clear zone. Beautiful, isn't it? That's your clinical beauty. Just by looking at the eye, because sometimes you show me pictures, ma'am, is this arcus? Then I say no, and then I don't tell you anything more than that because it's way beyond it. Okay, so if at all in your OPD you are seeing an arcus senilis, something like an arcus senilis, but you realize it's so thick and there is no lucid interval of Vogt. So what should you do? You should do a lipid profile. You should do a fasting lipid profile. Whereas for a normal arcus senilis, you don't have to do any investigation. Do you understand? A simple examination, not even a torchlight, you are going to do a lot of investigations, or you run through things in your mind. All right. So that was question 1, and we've discussed a lot. Now what was question 2? Mutation of LCAT gene causes. I've already explained to you, which is your fisheye disease and Norum's. Now in Norum's, apart from what you have in fisheye disease, like a lipid deposition in the cornea, do you have anything else? See, there's so much of cholesterol, free cholesterol in the body because complete LCAT deficiency. So this excess cholesterol, where does it go? It goes into the RBC. So now my RBCs are not normal. So what happens when it goes into the spleen? It gets hemolyzed. So you get a hemolytic anemia. But what about the size of the cell? It's going to be normal. So it's going to be a normocytic hemolytic anemia you're going to get. Okay, so the patient can probably get jaundice. Now what kind of jaundice is it going to be? You're going to tell me whether it's going to have a direct a conjugated bilirubin high or unconjugated bilirubin high. You're going to tell me. Okay, so that's homework for you. You're going to push it down. And the next thing is, if there's so much of hemolysis happening, don't you think we're going to have a little bit of splenomegaly? Probably. Okay, and what happens is it deposits in the bone marrow. Okay, so you get a lot of foamy cells in the bone marrow. And you also get foamy cells in the glomerulus of the kidney. So the patient can have renal failure. So patient has a triad in Norum's disease. What is a triad? 1 is corneal clouding. Number 2 is, what was that? Hemolytic anemia. And number 3 is renal failure. So this renal failure and the hemolytic anemia do not occur in case of your fisheye disease, okay, because you don't have that much of free cholesterol here. All right, so what is a triad in Norum's disease? You got corneal clouding, and what's the next? You have hemolytic anemia, and the kidney is affected, proteinuria. So you can have a chronic kidney disease, a renal failure in case of Norum's disease. Okay, now in both of them it's the same gene. What gene? LCAT gene, located on the long arm of chromosome 16, but which codon gets mutated? It's 1, 2, 3. You remember you have a song. I forgot what's the song. You want to help from a friend. I'm there like 1, 2, 3. Okay, so 1, 2, 3 is fisheye disease, and codon 4 is your Norum's disease. Okay, it's simple. Okay, so we got all this covered. Now, do they have a premature atherosclerotic risk? No, both of them no. Unlike Tangier disease, which is associated with APCA4 gene mutation. Okay, so question 1 covered, question 2 covered. Let me take a look at what is question number 3. Okay, now question number 3 was, which of the following have cholesterol deposition in the cornea? So actually it was a multiple options. Right, so option A, fisheye disease, it's the entire cornea. Norum's disease at the limbus without the lucid interval. Option C, Schneider's dystrophy. Yes, Schneider's crystalline dystrophy, there is a deposition of cholesterol and other lipoproteins, okay, in the stroma, okay, in the stroma. And the diagnosis is, if at all you do a corneal biopsy or you do a corneal transplant and you're going to stain it, how would you stain lipids? You would stain lipids using Sudan black or oil red. Oh, all right. Okay, then arcus senilis, I just explained, it's a peripheral corneal degeneration where lipids are deposited primarily at the Bowman's layer and also at the anterior aspect of the stroma, but with a lucid interval of Vogt. All right. Tangier's disease, yes, we do. Tangier's disease also, yes, there is a deposition of lipids. So all of them, A, B, C, D, E. Okay, question number 4. Now question number 4, which of the following does not present with cloudy cornea at birth? Now this is based on something that I discussed yesterday. You remember I gave you the stumped mnemonic. So option A, so I'm asking which is not presenting with cloudy cornea at birth. Peters anomaly, stumped, it's there, P is there. Then posterior polymorphous dystrophy is part of the ED, endothelial dystrophy. I said except Fuchs, everything else presents at birth. So this does not present at birth. So this is not the answer. Hurler's syndrome, again M, mucopolysaccharidosis, everything except Hunter's have cloudy corneas. Hunter's has a clear cornea. I told you, remember, it's a very common mnemonic, all of us, a very common thing that all of us tell you that to hunt you need a clear cornea, a hunter needs a clear cornea, but what I've given you is Hurler's syndrome. Hurler's syndrome does have, so your option is you will just have to rule it out and you got fish eye disease. So most of you said Hurler's syndrome, I think you didn't read it right or you just got Hunter confused with Hurler. Okay, so you can hurl anything closed eyes, that's okay, but to hunt you need a clear vision. All right, so fish eye disease, so fish eye disease but cloudy cornea though is there. Then what is the point that makes it the answer here? That is because fish eye disease, the cloudy cornea does not present at birth. Okay, so every word counts. It does not present at birth, it presents in the adolescent age group or in the early adulthood. Okay, I got you there. All right, so next thing, the last question had a histopath image. So from an enucleated eyeball, there was a cross section. So you could see the lens touching the posterior aspect of the cornea. So that was Peters anomaly. Now Peters anomaly is a congenital anomaly. That's because the cornea and the lens have to be separated at one point because they are both developing from the surface ectoderm. So when that separation does not really happen in a smooth way, so you do get this what is called as Peters anomaly. So in Peters anomaly, you will have a central corneal opacity plus or minus a congenital cataract. Now, what is this central corneal opacity due to? You have what is called as a posterior corneal ulcer that develops. Okay, there's a posterior corneal ulcer, and very, very characteristically in this Peters anomaly, there will be absence of Descemet's membrane and endothelium if you see the histological section. So this little bit I will ask Dr. Ranjit to explain to you because I'm not great at pathology. Okay, I'm good, but in front of a pathologist maybe I'm not great. So I'll just hand over this to him one day and I'll ask him to discuss this for you. Okay, so there is absence of endothelium and Descemet's in this posterior corneal ulcer area. All right. Okay, so there's a posterior corneal ulcer, there's absence of Descemet's and endothelium, and sometimes you can have, like in this case, you can have the lens touching the posterior aspect of the cornea, and also at times there can be iris, you know, the iris touching the cornea, the posterior aspect of the cornea. Now, Peters anomaly is associated with a couple of mutations. What all mutations? One is PAX6 gene, then there is a PITX2, FOXC1 gene, and also your CYP1B1 gene. Okay, you remember CYP1B1 we've read in congenital glaucoma. It is also associated with Peters anomaly. So Peters anomaly, PAX6 gene, PITX2, PITX2. Then we've got that CYP1B1 gene and also FOXC1 gene. So let's take a look at what all options I have given. Okay, PAX6 gene. So option A is the answer. Then I've given CYP1A1 gene. I don't know what it is. Now WT1 gene. You remember the Wilms tumor wala gene? Yes. So can I get aniridia when I have a WT1 gene mutation? Yes. Along with PAX6 gene mutation, I can get aniridia as part of the Weger syndrome. And Craigie gene is associated with congenital cataract. Alright, so that finishes this ICQ, integrated clinical question discussion, where there is also ICQ, lot of I wala clinical questions, and also it's an IOSCE because one question is definitely related to the other. You know, I'm like taking it through like a story. I hope you did understand a lot of ophthalmology, a little bit of biochemistry, and what else? Yeah, little bit pathology, I think. Okay, so Tangier's disease, there are some eye findings. I mentioned that as well. So what all do you get? You get a cloudy cornea. Then you get what is called as a cicatricial ectropion. Now what is an ectropion? Have you heard of cicatricial ectropion? Can you give me 3 causes? Ectropion. Cicatricial ectropion. One is probably you have like a scar outside which is causing a cicatricial ectropion. Then you have it as part of blepharophimosis syndrome. You have a lateral cicatricial lateral ectropion. Okay, not really a cicatricial ectropion. And then you also have Tangier's disease. Okay, Tangier's disease, APCA4 gene mutation. And yes, you have what is called as a decreased corneal sensation, which can also occur in Tangier's disease. Okay, so Tangier's disease, 3 clinical findings in the eye. What are the 3? One is you have a corneal clouding, then you have cornea, decreased sensation, and cicatricial ectropion. All right, so there we go, we finished. So tomorrow again I'm going to come up with 5 questions for you where you revise Ophthal and also other subjects with me. Okay, bye guys. This is just purely for the love of learning. I love to learn and I also love to share what I learn. Bye all.